coming along. For those that don't know me, my name's Chris Pell. I'm a consultant psychiatrist down at Carsview Centre, looking after the one of the inpatient wards down there. I've just sent Tom off on a wild goose chase to get his laptop because we were having technical difficulties, so he will come back at some point. Got a talk on Madness Cured with Electricity, which was one of the original newspaper headlines when the Electroconvulsive Therapy was invented. It's a look at what's seen popularly as a controversial topic, although from a psychiatrist's point of view it's not really that controversial at all. But we can look at the history, how it developed, why it's perceived as controversial, what we actually do, whether it works, and some ideas about how it might be working. I think to consider as you go through the talk, would you consider having ECT yourself if you were severely depressed? So yeah, have a think about how you feel now, how you feel at the end. So there's a sense of differing opinions about ECT. My patients tend to think that it is old-fashioned. They're often surprised that we still carry out electroconvulsive therapy. The media tends to be swayed by the films and popular portrayals within film and media. Scientologists have an even dimmer view. They've probably got the worst view about psychiatrists in general, but they think that we're barbaric and torture everybody with electrical shocks. The nurses think that I sort of stand by the ECT machine and pontificate and direct things. I think I'm doing loads of interesting neurochemical stuff because that's what I like to think in terms of the medical model. And what I really practically do is help out delivering the treatment. The Royal College of Psychiatrists would say that ECT is a proven effective treatment for depression, safe even in the medically ill, the elderly and pregnancy, and it can be used both first line and for treatment-resistant conditions. We'll talk a little bit more about that. At the other end of the spectrum, we've got, this is from the Psychiatric Survivors Guide, which is from the Citizens Commission for Human Rights, a Scientology-funded website that says it's about destroying the brain, they're destructive, they reduce the size of the brain, and counteract any physical pain or any kind of emotion. There's one bit of that statement that I agree with, and that's that it's one of a number of psychiatric treatments that relieve suffering, but the rest of it is unfortunately for the Scientologist bunkum. So, why is it conceived as unpopular? Well, the media doesn't help. If I can get some sound. Let's see if I can avoid demolishing the equipment in the process. Sorry. It's got a faulty connection. Okay, well, we may never know why it's so badly perceived in the media. If I can get the display back on, I will do that. But there have been studies of psychiatric portrayals in films. There were 2 studies, one looking at 22 American portrayals in films from 1948 up until 2001. They found that by and large the perceptions and the ways that ECT was described were very negative. It was usually unclear that there was any consent given. It was often unclear whether any anaesthetics were used. It was often used as a form of punishment, or even in some horror movies for the effect of killing people. And you might assume that, well, that's the last millennium. Have things not just improved over time? Well, no, unfortunately, the follow-up study that was published in 2016, looking at films from the new millennium, showed just as dim a view as it had in the past. So there were 39 portrayals, so the number of films and television portrayals of ECT had increased, yet they were still showing that anaesthesia was only used in about 15% of those, and it was unclear in a couple of others. It was used for slightly odd purposes, so depression, bipolar affective disorder, schizophrenia, schizoaffective disorder, so far so good. But it was also used as a treatment for substance misuse, oppositional defiant disorder, multiple personality disorder, PTSD, and epilepsy. Epilepsy, possibly, because it is anticonvulsant in itself. Or it was used for supernatural reasons, and torture and murder and things like that. So not the best. Whether they used EEG monitoring, whether they used muscle relaxants, whether they used any form of bite block, were also only about 15 to 20% showed positives. And there were only actually 5 television or films that had all of those 5 components that are really seen as the necessary cornerstones of modern ECT. As I said, 9 of the 39 scenes showed ECT being used as an instrument of torture, punishment, or murder. 6 of them were used to wipe people's memories, and there were very few that actually did it properly. The delivery of ECT was usually by doctors and nurses, but there are examples of it being used by a ghost and also by the Joker in Suicide Squad. And I guess if you're looking for positive portrayals of psychiatric things, a film that's entitled Suicide Squad is probably not the best place to look. But he uses ECT to essentially shock Dr. Harleen Quinlan into being Harley Quinn, which is deviation from the comic, but anyway. So how do we get to doing this? Obviously, people think it's a weird thing to do. It does seem like a strange thing to do, but it's actually been around for a long time. The use of electricity was first described in Roman times. There was a chap called Scribonius Largus who treated the headaches of the Roman emperor with an electric eel. I think if somebody put an electric eel on my head, I would stop complaining that I had a headache. So that might be why it worked. And there were some indications from Paracelsus in the 13th century that convulsions had been used, giving camphor by mouth to cure lunacy. As we moved into the modern era, there was a desperation, really. The asylums that had been instituted in the Victorian era were building up, the populations were ever increasing, and there was a lack of effective treatments. So it may come as a surprise that there were 2 psychiatrists from the sort of pre-1950s, before psychiatric medication was invented, that won the Nobel Prize for Medicine. One was a chap called Julius Wagner Jauregg, who introduced malarial cures for tertiary neurosyphilis. So he got the Nobel Prize for Medicine for deliberately infecting his patients with malaria, in the knowledge that when they had a fever, they woke up out of their comatose state, and if you could do that at least 1 day in 3, that was a better quality of life overall. That was how bleak the prospect was for some of the treatments in long-term psychiatric care. The other chap that got the Nobel Prize for Medicine was Egaz Monitz for frontal lobotomy in 1949, and again that has been widely discredited, but at the time was cutting-edge science. The beginnings of convulsive therapies started not with electricity but with proconvulsant drugs. So Ladislav Meduna in the early 1930s introduced wet shock therapy. He had observed, and this is anecdotal, it's not supported by later evidence, that schizophrenic patients had a better prognosis if they were also diagnosed with epilepsy. So he reasoned that by inducing convulsions you might treat the schizophrenia. He tried lots of things, including strychnine, thebaine, caffeine, absinthe, which sounds like a decent trial to get involved in, and he eventually came up with inducing experimental epilepsy in guinea pigs using camphor, and then proceeded to human trials. And he treated 26 patients and published, and it took off. It did have an effect. But you couldn't control for the length of seizures. Prolonged seizures were quite common, and fractures, particularly of the long bones, and vertebral crush fractures from prolonged tonic phase were a real risk. So into the latter part of the 1930s, two Italians, Ugo Saletti and Lucio Bini, started to look at whether electricity could be used to induce seizures. And in terms of trying to improve the image of psychiatry for these things, the story is not the best. They did 5 years of animal studies. That's a good point. But a lot of that involved dogs dying of electrical overload to their heart, because the original placement for the electrodes that they were using was one in the mouth and one in the anus. And I'm sure our patients are a lot relieved to find that that placement has changed over the years. Bini went across to a conference in Switzerland in 1937 and met Ladislav Meduna, and they got talking about convulsive therapies. Meduna confirmed that he didn't think it was the drugs themselves, he thought it was actually the convulsion, and that kind of rekindled Bini's thoughts of electrical stimulation to cause convulsions. Back in Rome, he was reminded by a colleague of an abattoir that was using electricity to kill pigs for slaughter. This is not the best in terms of selling this as a conventional and usual treatment. But they did go down, and they found that there was a wide safety margin, that the fatal dose was a lot higher than the dose needed to induce grand mal seizures, because some of the pigs have been exhibiting that, and that you needed a very long stimulation for a fatal dose. So they came back to thinking about, well, could we adapt this? Could we use it as a means of artificially inducing convulsions? Different ethical paradigms. So once they had built their equipment and tested it in animals, they got patients. So they moved very rapidly to human trials in 1938. And they got a chap who had been at the Rome train station who was babbling. He incoherently talked and was ununderstandable most of the time, and they tested their equipment. Unfortunately, the first treatment, they didn't give a high enough dose, and so he didn't have much of a response, except to say in very clear Italian, "Don't do it again, another time will kill me." But that was clearer than anything he'd said hitherto in his admission. So after another week, they had another go. This time they did induce a generalised tonic-clonic seizure, and by the 17th of June, so that was April, by the 17th of June, Enrico, the chap that they had found, was discharged from the hospital back to his family. They presented their findings to the Academy of Medicine in Rome, and they also went to the media. And that's where the headline came from, with madness cured with electricity. There was a period where it really took off, to the point where there's a snippet from the local paper from Montrose Asylum, from Sunnyside, where they're complaining about the effectiveness of this treatment. This is in 1943, Dr Anderson was using it, in that people were getting better too quickly. And so the fee-paying component of the hospital, they were losing money. So yes, it's kind of one of those good news, bad news things. Yay, people are getting better. However, our income and our take is down. The initial application of the treatment was an improvement, a modest improvement on the complication rate. So because the seizures could be tailored, they could be limited, and it was reasonably quickly established that a few seconds, 15 to 20 seconds, was sufficient. The risk of fractures was greatly reduced. But there were still some cases where fractures occurred, particularly the vertebral crush fractures. So people began to think, well, how can we modify that? And this is where it moves into the modified ECT that we use today. Curare was known about at the time in the early 30s. Do you know the story of the donkey? And the original finding was that in 1825 Charles Waterton kept a curarized donkey alive with bellows and a tracheotomy to demonstrate that it was a paralytic agent and not a toxic agent. So that was the demonstration. And people tried to synthesize it for the treatment of contractures and spasm. By the 1930s, they'd managed to get tubocurare through from the Amazon. They were starting to synthesize it, but it was a complicated extraction technique, and they were looking for less complicated molecules. They eventually came upon the methonium group, and succinylmethonium, which is basically two acetylcholine molecules stuck back to back, was basically invented at the same time by three independent groups in late 1949. It had rapid onset and offset, and it was less hazardous all round. So it began to be introduced to the field of ECT because short-acting muscle relaxants were ideal. There was a very, very brief window where it was used without anaesthesia. And one of my favourite questions for medical students coming through the ECT clinic is, why do we anaesthetise the patient? And they by and large assume that it's because ECT is so terrible. It's actually because being paralysed and having your respiratory muscles paralysed before you go off to sleep is much more unpleasant than the ECT itself, because ECT renders you immediately unconscious. You usually have a fuzzy awareness for it. So it was only with the introduction of these short-acting muscle agents that people began to complain of the uncomfortability of it. And thereafter, really, modern ECT was born. People have different views. The media, the Scientologists tend to dispute these things. There was a backlash in the 1960s from the sort of anti-psychiatry leanings. Prominent writers like Thomas Satz and R.D. Lang, Michel Foucault in France, began to say that we had moved too far away from understanding the causes and doing proper in-depth psychodynamic psychotherapy to a more medicalised form of psychiatry. But the results were speaking for themselves by that point. I think that's where things have got complicated. There is a competing interest in that these groups might like you to sign up to their way of dealing with psychiatric problems and give them lots of money and fall into the same traps as people like Tom Cruise and John Travolta unfortunately have. Modern ECT in Scotland, we know a lot about how ECT is delivered. We have some of the best monitoring in the world because we have a centralised database that's monitored by the Scottish ECT Accreditation Network, or SEAN, and they provide an annual update, and they look at all ECT delivered across the country. So we know quite a lot about what goes on. There are 18 sites currently that deliver ECT, most of them clustered in the central belt, but we have 3 in Tayside, at Stracathro Hospital, in the Carsview Centre in Dundee, and in Murray Royal Hospital in Perth. Across Scotland, the most recent data we have is up to 2016. There were 344 people who had ECT, and that totalled about 3,800 individual treatments or shocks given. The average is 9 treatments, so most ECT is delivered twice a week, so that's getting people to remission in 4.5 weeks, which is pretty good. And it's most commonly given for recurrent depressive disorder without psychosis. That was about half of the cases that were there. There's about 10% where the treatment is given as a life-saving treatment, and often people are surprised that we would term depression a fatal illness in that way, but people do succumb to the inactivity, the dehydration, and where they can't motivate themselves to eat or drink, death is a real risk. So a good proportion are given for that indication. And the other surprising thing perhaps is that almost a third of episodes happened in patients who had expressed a desire to have ECT, either because they had had a good experience previously or because they had heard positive things and been persuaded to opt for it. Numbers of patients over the years have been fairly static for the last decade. There are about 400 people on average in Scotland per year, and it's done in a very clinical way. We have an anaesthetist, anaesthetic nurse, a psychiatrist, and an ECT nurse, and often trainees and students and things. But it's done certainly in the clinic that I was running in Stracathro. We used the theatres, so we had all of the accoutrements that you would want from an anaesthetic safety point of view. It's given twice a week. Patient comes in. They're given a muscle relaxant. They are, other way round. They're put off to sleep, they're given a muscle relaxant, and then the treatment is induced once the paralytic effects are in place. And that minimises the amount of muscular contractions. There are still some, but it is very minimal that you're aiming for. The placement of the electrodes is something that's been refined over the years. You can use bilateral, which is bitemporal, or you can use unilateral, and it's usually right unilateral because we want to stimulate the non-dominant hemisphere to try and avoid cognitive impairment. So unilateral tends to be a little bit more practically difficult to administer, but you are preserving any cognitive changes. So if somebody is complaining of that, you could switch from bilateral to unilateral. We look for EEG monitoring, and that's a two-lead EEG, so we're just comparing the two hemispheres to a single neutral point. And what we want to see on the tracing is a seizure lasting around about 15 to 20 seconds, but the quality of the seizure is probably the more important part, that you want to see a good induction phase, so a recruitment of neurons, and then the tonic-clonic, so delta wave or theta wave activity, gradually petering out, and then ideally some post-ictal suppression from baseline. And if you've got 2 out of 3 of those components, that would class as a therapeutic seizure. Those are the things that are associated with treatment effect. We would titrate up the dose at the beginning of somebody's treatment episode, so that we would begin with a very low dose of electricity, about 4% of what the machine could deliver, and gradually build up to find the individual's seizure threshold. The way it's delivered is not like defibrillation, so it doesn't all go in one thump. It's given as a square waveform, so a positive and negative waveform, and you can alter the parameters of that and the amplitude and the frequency, and it's delivered over anything up to 6 seconds, so a much more gradual dosing of the electricity. In terms of safety, it's pretty safe. There are some absolute contraindications, but again, if somebody is going to die of their depression imminently, how absolute they are is sometimes open for discussion. But that would be somebody who had had a recent myocardial infarction, recent stroke, perhaps an intracranial mass lesion, because you wouldn't be certain of how the electricity was going to be distributed around their brain. And relative contraindications would be the kind of lesser forms of that, so angina, congestive heart failure, pulmonary disease, osteoporosis because of the risk of fractures, and pregnancy is a relative contraindication. A lot of them are geared towards the anaesthetic risk, so if you can tolerate a general anaesthetic, there's not too much in the way of additional overlay of ECT causing risks, but it can be energetic. A seizure is energetic, so you're wanting to avoid strain on the heart, strain on vessels that have been damaged previously. In terms of significant adverse events, out of the 3,800 stimulations that happened in 2016, only 8 led to a critical incident. So that's 0.2% of the treatment. So again, pretty good safety effects. In order to look at mortality statistics, it's about 1 in 80,000 treatments that lead to death. And the risks of not treating are actually a lot higher, because there's a risk of around 10 to 15% mortality from depression due to suicide. Physical side effects tend to be mild, self-limiting, but common. About 2/3 of patients will complain of at least one side effect. The most common is headache, and that's because you're directly stimulating the muscles of the face in the application of the seizure, and you will see patients grimace as you deliver the electricity. A lot of people assume, oh, they must be in pain because they give you a kind of face. Well, no, they're anaesthetised already. They're not experiencing any sensation at that time. It's a purely electromotor effect. Other sorts of problems that people will complain of are memory problems. And we do warn people about short-term effects of ECT, so some anterograde and retrograde amnesia around the time of the treatment. It's one of these things that's difficult to disentangle from the symptoms of a severe depression in itself, because that can also affect your concentration, your memory, and your ability to learn new information. When we follow people up, most of those effects are back to normal baseline by 6 months post-treatment, but there are a small number of patients who do report ongoing episodic memory change, so they will feel that their autobiographical memory has been changed or bits of it lost after a course of ECT. Again, it's complicated to get a research paradigm that can elicit whether that's down to the ECT or not, because the sorts of things that they might say are, well, I can't remember going to Auntie Mabel's wedding in 1972, or I can't remember the colour of the first car I drove, and there's not a memory test about that will ask those sorts of questions and allow you to later follow them up. So it's been difficult to try and disentangle, but it's certainly something that enough people have complained about that is now part of the consent procedure for ECT. In terms of consenting, again, the statistics are often a surprise to people, but more than 70% of people give informed consent for ECT. Most of those, the vast majority, 2/3 of treatments are given to patients who are voluntarily in a psychiatric hospital. There are about another 5% who are detained under the Mental Health Act, but who are capable of consenting to the treatment nevertheless. And in the rest, the other third, capacity to give consent is impaired, and therefore a second opinion is sought from an independent doctor sent by the Mental Welfare Commission, who will authorise whether it's a reasonable treatment or not. For life-saving treatment, you can initiate the treatment in advance of that second opinion, but once they have come, it can only proceed further if they are in agreement that the treatment is necessary and reasonable. So there's a very small percentage of people who have ECT, as the media would put it, forced upon them. You cannot give ECT in Scotland to a capacitous adult who is refusing. That's slightly different in England, but in Scotland we have a fairly sensible threshold for these things. Does it work? What's the effectiveness? Well, yeah, it is effective. It is one of the most effective treatments that we have in psychiatry. It's one of the most effective treatments that there is in terms of numbers needed to treat across most of the treatments that are delivered in the NHS. About 63% of patients will have at least a 50% reduction in their depressive symptoms. And if you look at the subset of the most severely unwell patients, it's about 86% of them will have a halving of their depressive symptoms by the end of treatment. And that's substantial. That's the definition of going into remission. Another 25% will have improvement up to 50%. And so there's only 10% of patients who show either no improvement or worse outcomes with with the treatment. So your odds of improvement are really quite substantial. And the more severely unwell you are, the more likely you are to benefit from the treatment, which is similar to other treatments that we have. The other part of it is the anaesthetic considerations, and there are things that do need to be taken into account in terms of both the location of clinics, so they may not be in a big teaching hospital with lots of anaesthetists and theatre staffs about, and there are guidelines from the Royal College of Anaesthetists about the use of anaesthetic services in remote and rural sites. You may have to take into account patient factors. Often patients are elderly. They may be poor historians due to the severity of their illness, so you may not be able to get a fully detailed medical history. And you need to think about the practicalities on the day. We would always send an escort nurse from the ward that the patient is in along with the patient, and they stay with them throughout the treatment and through recovery, and then bring them back to the ward, so they've always got a familiar face with them. And there are provisions under Sean, the accreditation network, about the length of time that you can wait. They shouldn't wait more than half an hour in the waiting area before their treatment is delivered, and all the descriptions of what the equipment should be like. What happens during a seizure? Again, from an anaesthetic point of view, you're going to be thinking about the cardiovascular strain. So it's akin to getting the patient to run up a flight of stairs. So you get increases in heart rate, you can get increases in blood pressure, there's a myocardial oxygen demand. There's also a potential for bradycardia and even asystole post-treatment. And there's case reports of asystole up to 28 seconds that spontaneously resolved. You would hope that the team was preparing to give them something to unspontaneously resolve it, but there are these cases. I've seen it a few times, maybe 6 or 7 seconds of asystole, and then it kicks back in. And you can use glycopyrrolate to try and mitigate against that. You get cerebrovascular demand, so again increased oxygen consumption, increased blood flow, and increased cranial pressure for a little bit after the seizure. And you also have to think about the sort of general effects. What are you going to do if this seizure doesn't remit on its own, and have benzos on standby and things like that. Choice of induction agents is reasonably wide. Propofol tends to be the most common induction agent used. Etomidate we sometimes give, particularly if you need to try and lower the seizure threshold. So if you're getting up to quite high doses of electricity and the seizure length is shortening because the seizure threshold does increase through the treatment, etomidate can be a good one to do that. And then you've got things like methotrexate, thiopental, and ketamine, which is increasingly interesting. There's a lot of research going on about ketamine's effects as a rapid-acting antidepressant drug. We know that it tends to work on the NMDA receptor function. It also causes downstream neuropsychiatric effects. It promotes the release of brain-derived neurotrophic factor, which is kind of a general good all-round brain tonic chemical, and also things like GSK3, glycogen synthase kinase, which is again one of these interesting chemicals that pops up in a lot of metabolic pathways, and its sort of neuroprotective effects are being explored. It's one of the main mechanisms that is being looked at for how lithium might function in the brain. But despite all that, ketamine and ECT, although they've been used together since as far back as the 70s, there hasn't been a strong signal emerging that it's any better to combine the two with ECT. It's been quite mixed in terms of the studies that have come out. There's more studies coming out for using single bolus ketamine doses for people in high levels of distress or as a rapid antidepressant, but the main application of that, it would seem, would be to give it to A&E departments so that people coming in with self-harm could get a dose of ketamine and calm down. I think that would be hard to police if you told everybody that the A&E department was giving out ketamine for people that turned up in distress. So the practical issues. The final bit, looking at criticisms of ECT, one of the things that we hear is, well, how can you use this treatment? You've no idea how it works. Well, we do know some things about how it works, and also you can throw it back and say, well, people have been chewing on willow bark since the 1600s. And nobody really minded that we didn't work out how aspirin worked until the late 90s, early 2000s. Paracetamol, there's still some debate about the exact effects of that, and a lot of the other medicines that we use in psychiatry, like lithium, antipsychotics, we know that we don't know the full picture. What we do know about ECT is what it does, and often the difficult bit is then thinking about, well, why is that important? But in terms of general effects, sort of macroscopic effects, there's increased cerebral blood flow, increased intracranial pressure, and increased oxygen demand. There's an immediate parasympathetic effect, so bradycardia, hypotension, and then you get a slightly delayed sympathetic effect, which will give you the tachy and hypertensive changes, and you get a rise in body temperature due to the convulsions. Is any of that a factor in helping with mood? Well, it's not clear. The things that do have a better link are the neurotransmitter effects, and it has a wide effect on most of the major neurotransmitters, including noradrenaline, serotonin, dopamine, and GABA. And it also promotes second messenger potentiation at the dopamine D1 receptors. You get increased cyclic AMP, you get increased inositol triphosphate levels, so there's probably second messenger effects going on, gene switching intracellularly, and probable expression of different proteins, and that's something that as the human proteome program rolls on, we may get more information about. Some of the most promising findings have come from brain imaging studies, and particularly the team up in Aberdeen that was headed up until his untimely death by Professor Ian Reid, had started to look at the changes that you see in neural signaling and neural connectivity. So we know that from standard images that the ECT does not shrink or damage brains. It can actually increase the brain volumes in those areas that are prone to neuroplasticity. So the hippocampal volumes can be altered. What the group in Aberdeen looked at was functional connectivity. So if you can take two snapshots with an MRI and combine that with DTI imaging, so the axonal tractography, you can say, well, area 1 is active in this picture, it's connected by a tract to area 2, which is active in the second picture, therefore A activates B. And you can start to build up a bit of a wiring diagram for the brain. What they found in depression, or what has been found, is that there is an increased area of hyperactivity between the dorsolateral prefrontal cortex, or left prefrontal cortex, and the limbic system in the state of depression, which again is surprising because you would think depression is all about reduced firing, reduced cognition. So the theory is that there is a circuit set up that is actively reinforcing negative cues from the environment, or it's actively suppressing positive cues, positive emotions, positive memories. What's been found with antidepressant treatments is that pathway is reset down to baseline, and they had looked at that in ECT, in the ECT clinic up in Aberdeen, and found the same association. So further studies are needed, but we might actually be homing in on some of the neural basis for what's always been seen as a slightly very nebulous and difficult to pin down concept. So we still have questions. There's a lot of active research going on, but as the scanning technologies are improving and we're getting better resolution and better flexibility of what we can do with the scanners, we may find some answers that we're looking for. So hopefully that's been a whirlwind or whistle-stop tour through the world of ECT. Hopefully it's challenged some of the views that people might have about the treatment before the talk started. And again, I'd ask you to consider is it something that you would consider if you were severely depressed? Is it something that you might think about if you encounter a patient who is severely depressed? Thank you. Thanks so much, Chris. I'm sorry about the IT failures and everything. I will try and sort something out so that we can provide you with some of the slides, and I'll sort that out now. Has anyone got any questions or any comments? Oh, I'll just activate this and we'll hop around.
So, obviously, clearly from what you were saying, it works really, really well. I was just curious, what are the rates of relapse with people who are treated with ECT compared to people who are treated with just conventional medications and therapy?
Yeah, it's one of these things where the effects are not long-lasting. They persist for maybe a month or so after the treatment course is finished. What we would tend to do to get around that is to start people on an antidepressant medication at the same time as starting ECT if they're not already on something, so that by the time the effects of the antidepressant have emerged, again 4 to 6 weeks down the line, it's there to prevent them, to reduce their chances of relapsing. If you just did ECT, you probably see that people would get their symptoms back as time goes on. If ECT is the only thing that works for people, then you can look at maintenance ECT, where instead of giving it twice a week, you then move to weekly and eventually to fortnightly and ideally to monthly, so that people just come back once a month for a single treatment session, and that keeps the momentum going from the ECT itself.
Do you maintain that for quite a long period of time?
You can do anything up to a couple of years, I've seen, but again, there's still debate. It's something that's becoming used more often in Scotland, and it's skewing the mean results. The mean number of treatments has gone up over the years, partly because there are more people having maintenance therapy, and there is a lack of clear evidence about when exactly do you stop, and if nothing else works, can you just keep going indefinitely?
Thank you very much. Very, very, very interesting indeed. If I can, 2 questions. Firstly, you mentioned numbers needed to treat. I don't know the literature at all, but could you give us some kind of overview of the size of the literature or the evidence base for ECT in terms of quality and quantity of trials? Mm-hmm. And then the second question was perhaps relevant in terms of people who may have a lot of ECT over years, and you mentioned cognition issues, particularly why you might just use right-sided electrodes, for example, because of cognition issues. What is the impact of cognition or cognition problems as a consequence of long-term ECT?
Mm-hmm. Okay, so there's a lot of debate about the quality, the content of the initial studies that were done, because it emerged in the era before randomized controlled trials. There have been studies that have been done through the sort of 50s and 60s and 70s looking at the effectiveness of ECT versus sham ECT, where they would do all of the other bits of it, including anaesthetize them, and just not give them a dose of electricity, and it by far outperforms placebo ECT in that sense. It outperforms the antidepressants themselves, so it is, in that sense, one of the most effective treatments. The people that criticise ECT and criticise the research around it would say that the studies are small numbers, that they are perhaps not... I don't know off the top of my head. There's a clip in the slides from a Newsnight documentary a couple of years back, which was called "Why We're Still Using ECT," and they show both sides of the debate. So it's mentioned in that. But again, it's a difficult one to do because the numbers of people having ECT are reasonably small. The number of people that can give informed consent to take part in a treatment trial are small. So it is an area that's hard to get the numbers from, and because it's kind of got the established treatment effect, it's then to go and randomise somebody to something else is somewhat unethical. So that's some of the limitations in doing the comparisons. What was the second bit that you'd asked? Yeah, cognition. As I say, most people will find that the effects are transient. So we follow people up at 3 and 6 months post-treatment and do usually I use an Addenbrooke's cognitive examination, and we see that things do pick up back to baseline. Again, with depression also having an impact on cognition in the longer term, that there are effects that are difficult to tease out. The people that do report the more distressing form of autobiographical memory loss, again, I don't know if there have been studies done, but one of the things I think would be interesting to look at would be anxiety levels in those patients, or the personality styles of those patients. Because I think there is something about people who are perhaps overly self-checking that may report these things more commonly, that they become concerned that because they find that their memory is fallible, as we know it is anyway, is it just that they've become aware of that and are fitting it to the ECT, whereas if they've not had the ECT in the first place, would they just sort of dismiss those things as, oh, I'm just a bit absent-minded?
Julian, one question I had was, you said that about half of the people who get ECT get it for major recurrent depressive illness without psychosis. What are the other half?
Yes. The other indications would be for, so you can give it for treatment-resistant depression that is not necessarily severe, but moderate and unremitting and not responsive to other forms of treatment. You can give ECT in treatment-resistant bipolar affective disorder, so intractable mania. And again, that surprises people because people often think of mania as being the opposite of depression. But and you can give it for treatment-resistant schizophrenia. The other thing that it's very, very effective for is catatonic schizophrenia, so catatonic stupor. It's almost approaching 100% cure rates for that condition.
Excellent. Okay, well, it's cracking on for 2 o'clock, so I'd just like to thank Chris again for stepping in at a fairly late notice to give this talk. I apologise again for the IT. We'll try and get something out to you so you can see the slides that he spent ages preparing. Next week, Professor Margaret Hellard is coming from Australia. She's here at the invitation of Professor John Dillon and the hepatitis C group, who you'll probably remember from last year or years before. John is doing a lot of work with the Scottish Government to try to make Dundee the first hepatitis C-free city in the world and Scotland the first hepatitis C-free country in the world. But it seems they've got a lot of competition from Australia. So she's going to come over and talk to us about that. So that'll be fascinating stuff. And the following week it's the annual DCAT lecture, which we're maintaining the GI theme, is going to be esophageal cancer. I'll send out some more information about that next week. So thank you very much, and I'll see you again next week.